Welcome everyone to session 2 titled Latin America Humanizing Healthcare. We are excited and honored to be joined by our moderator, Kawal Butami, CEO of IEEPO, and our
y a la doctora Mayra Calefi, presidenta voluntaria de la Federación Brasileña de Instituciones.
president of the Brazilian Federation of Philanthropic Institutions in support of breast health, FEMAMA. You can find our full biographies on the official first virtual Latin America Patients Congress page on IEEPO's website. And before we get started, remember to use the Q&A tab. You can use the right button you have in your screen to make a question. Now I invite Kawal Butsami, our moderator, to take the floor.
Thank you very much, Stephanie. I think I would start off with some background first. That we were in Geneva again talking about humanizing healthcare, and the issue came about from the pandemic, first of all, when we all witnessed. And those of you have this memory fresh of having lost someone loved one, you saw how almost indifferent the health systems had become. They didn't care. There was lack of understanding, and there were people dying in the streets, not being attended to. There were people being rushed into hospitals, lack of oxygen, and I think that traumatized everybody, not only the patients, but also the health professionals and carers. And Raquel suggested this topic way back through, again, IEEPO, which is the International Exchange of Experience for Patient Organizations. And this idea started then taking its own life as it went along. And now it's the sixth generation, but we had a discussion with the health minister from Bhutan in Geneva. And as you know, Bhutan has got good principles on what is called compassionate and humanizing healthcare. And we would like to take that idea forward. Now, I will ask Raquel to come on first to start setting the scene. And then I will ask Myra to fill in the gaps. As you already saw at the earlier session, Myra did start talking about that compassion. You know, when you see surgery that shouldn't have happened, you know, that it should have been treated way better before this, and then the outcomes that affect people, the rehabilitation needs and all that. Raquel, over to you.
Thank you so much, Kawaldip, and thank you to you, IEEPO, and the organizers of this event. I am so honored to participate, particularly because I love this part of the world so much. After all, it does hold my beloved Brazil, which I miss so much, but also amazing friends and advocates from various other parts of the region. So, as Kawaldip explained, I was asked to present on humanizing healthcare, and I would love to start by sharing a quick story. So if you just go to the next slide, please. And I'll be very brief, but just to set the scene, a couple months ago, I met a liver cancer patient. So my background is in viral hepatitis and liver disease. And interestingly, this patient was also a doctor. And he was telling me how difficult and how frustrating it was for him as a patient to navigate the health system. And mind you, he's based in Canada, so he does have a very nice health system to navigate. But that got me thinking, so as someone with extensive medical knowledge, like this patient, doctor-patient, as someone with contacts, with resources, he still was facing all these challenges to get the tests, the appointments, the treatments. So if this is happening to him, then what chance has anyone else have? So what is happening to the other patients that are navigating different health systems that don't have a medical degree, that live far away, for instance. And another thing that he told me was that on several occasions, he stopped feeling like a doctor, he stopped feeling like a patient, a person. He felt like a number on a clipboard. And I think that that's the way that I'd love to get us into this topic of humanizing healthcare, and maybe move to the next slide figure it out a little bit with you, what we mean by that. So let's for a second imagine a health system that is compassionate, that is caring, and where those four elements, and I think I was having a bad mathematics day on the day that I presented, because I put 5 on screen, but I mean 4, so I was having a bad day there, apologies. But imagine like a health system where we have those 4 key elements as permanent features. We have respect, we have full participation and involvement of the patients in decisions about their health, which then implicates in interactions with the health systems at all levels. We have empowerment for information and a more holistic approach to care. And by more holistic, I mean not only looking at the symptoms or diseases, so we stopped to talk about cancer, diabetes, rare diseases, hepatitis, but we're now looking at people, their circumstances, and their stories. Can we go to the next slide, please? Could we also think of a health system that respects diversity and treats everybody equally? Because if we're talking about humanizing healthcare and looking at people, well, guess what? People are different. We're all different. And in fact, the differences, they don't only stop at how you look, how old you are. They also include differences around where you live, urban versus rural settings, how far you are from the clinic, differences around language, your literacy, your culture. And just while we're talking about language, let me just say a little bit here, because it's not only about, I speak Portuguese, you speak Spanish, Cavaldeep speaks English. It goes beyond that. We're talking about also linguistic barriers between medical professionals and then patients, and that creates power imbalances. So we know that the medical setting has always been very paternalistic, doctors as gods, so especially in our region. So a cultural shift is needed. It's not to say and to acknowledge the expertise, but we come in as partners. Okay, can we please move to the next slide? Thank you. Okay, so based on all of this, the IEEPO community, so not IEEPO, but IEEPO, as Cavaldeep suggested, of which I'm chair for now, well, we decided to stop imagining all this and then start doing something. So we surveyed patient groups across disease areas and across different geographies, and based on the answers that we received, we wrote a position paper last year on why we should and why, basically what would take to humanize healthcare. And both Cavaldeep and Mayra were also part of this effort. And this paper was centered around 5 key topics. If we just move to the next slide, please. I just realized we didn't move. Oh, there we go. That's the position paper. So if we can see now on screen, the position paper centers on 5 key topics and themes. And here I got my maths right. It is 5. So the first one is putting people at the heart of the healthcare. The second one is humanizing health literacy, which is very, very important. Number 3 is humanizing digital healthcare. 4 is a focus on prevention and cure with a 50-50 model. And here we're talking about 50% investment on prevention, which is, such a big gap right now, and then 50% on curative and therapies. And then 5, a prioritization of diversity, equity, and inclusion. And at the IEEPO website, you'll be able to find highlights of all of these chapters. But what I'd love to do now is, and I always like to do this, is just bring it back to our region a little bit more. So if we please could go to the next slide. So thank you. So I mentioned that we based the position paper on a survey. So what I want to share with you right now is some Latin American results from that survey and what was important for the patient organizations. And two themes were coming to mind. One was diversity, equity, and inclusion, which you can see in this slide here. And the next one is about putting people at the heart of healthcare. But let's pause here for a second. And you see that when we asked the Latin American organizations about diversity, equity, and inclusion, and the question you can see on your screen was, in your country or region, is there a strategy to adapt the way health service delivery and information is made available to different communities, depending on their situation and how they access information? Well, the majority either didn't know of those strategies or they didn't feel they had the knowledge to answer the question. And that indicates a big gap, perhaps an area for us to explore. If we go to the next slide, please. And here's about putting people at the center of healthcare. What came across very strongly was the need to treat the whole person. Again, not only the disease, the need for compassion. And if you see at the bottom of the slide, oh, I think we need to move, there we go. If you see at the bottom of the slide, 37.5% of the people that we surveyed claimed that individual needs of patients were not being treated with compassion. So what I'll do, I would like to start just wrapping this up a little bit by letting you know what our calls to action were in this big paper that we published, that we put out last year. Can we go to the next slide, please? And incidentally, if you see mistakes in my Spanish, I apologize. I tried my best, but I am not 100% fluent, so I hope it's okay. But these are the calls to action that came from this paper. First, we urge governments to recalibrate the delivery of primary and secondary care. We've increased investment in prevention. We need to look at stop people from getting ill and not having systems that only look at treating once we already get the disease. We also need the governments to develop inclusive strategies so we can achieve health literacy, we can reach diverse populations. But it's not only about governments. We also want schools, healthcare professionals, and academic institutions to partner with local patient organizations like yourselves, then to help develop health literacy and what it is, perhaps to understand what it is to be a patient in that journey. We need the technology industry to continue to invest in information technology, to bring patients and healthcare professionals together in a more trusted and equal collaboration. And us, looking at the patient organizations, we need to continue facilitating conversations with all stakeholders about the need and value of compassionate care, of humanizing healthcare. That's why we're so excited to be bringing this topic to you and start this movement. And you see that these calls target everybody, because it's not about only one sector, it's about us all. And we're not here to say, you should treat us with respect, doctors. It's, I'm being treated like a number, because sometimes, well, most times, if not all times, the doctors do want to deliver compassionate care or person-centered care, but they are overwhelmed, overworked, under-resourced. So this is a bigger calling than just targeting one sector and then telling it off. It's about systems change. And with that, I get to my penultimate slide. So if you could just move to the penultimate, you'll be happy to know I'm going to stop soon, very soon. It's almost last slide. And I just wanted to leave you with three messages. And as you can see, the three messages are: humanizing healthcare is absolutely key We've been hearing about rebuilding healthcare systems, rebuilding sustainable, strong healthcare systems, in every single conference. Well, it's not going to happen unless we humanize healthcare. Second, this is a huge effort and it's a system level problem. So it will require leadership from every sector, as I've mentioned. So everybody has a role to play. And then third, we can't play the role by ourselves. We need to collaborate. Just we can then start seeing the changes. And my last slide is a final, is if anyone wants to learn more about, and if we can move to the last slide. Yes, thank you. Is that if anyone wants to learn more about IEEPO, you can visit the website, but feel free to connect with me online or email. But I'll stop now because I know that Maida's coming in with more on the ground, day-to-day experience to what I've just explained. But I hope you enjoyed this brief introduction to this movement, and I hope you join it too if you're not joined already. Thank you so much.
Thank you very much, Raquel. I think one of the most important aspect on this is that humanizing healthcare shouldn't be seen as a luxury. It's absolutely an essential right within WHO power region and Latin America especially. And the other I liked is that we can't achieve this through discussion and thought. It needs to be worked harder, you know. As I say, you can't have great mangoes if you don't want to plant the mango tree and take care of it, you know. It takes years to get those mangoes. And then in Latin America, those who enjoy the mango season all know this, you know, that it's one of those things that look at. And I remember some of as Vargalotha was a writer. He used to say, if you're planting the thorn tree, why do you expect to see mangoes after 20 years? And he was talking about how to make democratic countries and so on. He says, if all you have done is planted thorn trees, then comes 30 years, you expect mangoes from it. I'm sorry. So let's look at this. Let's plant some mangoes. Let's make sure our health systems are able to be humanized. And I'll now ask Mara to come on board and discuss this, because I think Mara is the other passion. You know, she really keeps us going at IEEPO, even when we're down. And she has got this unique way of motivating us to join. And I think Raquel's already laughing. And she will come up with some amazing insights. So Mara, over to you. How do we humanize healthcare? You see it every day in front of you. On your table, you see humanity lying there helpless and waiting for you to help them. You are like God to them. Thank you.
Thank you so much, Kavaldip. I think what moves me, what makes me get up in the morning every day is that I'm going to see patients and I'm going to help them. And this is the reason of my life. You know, I think this is important for me to be part of a bigger movement, because I can see my role in one-to-one dedication, and I try to do precision medicine. I try to humanize not only the one-to-one care, but the whole team that I coordinated at the hospital, at the cancer center, because this is sometimes much more powerful than any chemotherapy or even any innovation. Because if you don't, the patient doesn't feel that that you are together with her, him, they feel like nobody's looking after. And I think this is, along the way, this is, we lost a little bit this idea, and trying to, even with the thing about not seeing patients person to person and going online. And this, you can be online and be humanized. This is also different. This is not only the eye and eye touching, is how much you put effort and see a patient as an individual, a human being. So because of my challenge every day to make sure that this patient will survive with quality of life, and this could be extrapolated to any, not only oncology. Again, I'm going to apologize if I talk about oncology because it's my life, my day-to-day, but it can be extrapolated because IEEPO is not about cancer only. And we're going to talk a little bit here about how we can strengthen the healthcare system to become more effective and more humanized. So I'm going to present next. So thank you so much for having me here this morning or this afternoon or this evening. I don't know. But next slide, please. I'm going to tell you that, and that should be, can you blow a little bit and leave it like that? Thank you so much. I think I need to tell you where from I'm talking to, because FEMAMA is an umbrella organization, a huge network in Brazil, and this should be pink. I think, I don't know how we didn't manage to. Are you seeing pink, Raquel? I'm just not. Well, the original slides were pink because we are dealing with only those, the dark slides. The dark side is where we have NGOs associated to FEMAMA. So we pretty much have in the whole country, like sometimes more than one NGO working together. This is the beauty of it. So I'm pleased to say that we just are enrolling to get closer to LAPAC and IEEPO. We're trying to be a member, and I hope we'll be accepted, and to make sure that we are going to put our efforts together to humanize healthcare, but also personalized personalized medicine. So I'm bringing here the national and international coalitions that we've been together already, and I want to call your attention for the UICC and City Cancer, because the City Cancer Challenge is placed in Porto Alegre as one of the 12, 13 cities around the world that are together trying to implement what the patients need. So sometimes in another opportunity, I can tell you what we are doing in those respects. And we are kind of having a lab in Porto Alegre, the city where I am based, and then we're trying to extrapolate that, escalate that for Brazil. But other countries in other cities are doing that as well. Colombia, we have in Paraguay, we have in Mexico, and there is one missing here that we are in Latin America. But the other one is UICC, and I'm already putting my candidacy this year for the board. So if you are a member, please vote on me, because we are going to work together in accessing to medicine. This is the thing that we wanted to do together there. I've been in the board before, and I think Latin America should be more visible in the UICC. Next, I think we've done a lot lately. Next slide, please. So we need to be credible about it. Patients groups are always at the end of the role and difficult to be a player when we're talking about healthcare systems. So we need to be very forceful sometimes to get results. And this representativeness of Latin America is something that I'm being after for a long, long time. I belong to other groups before, Latin American groups, but I don't feel that we succeeded. So please, let's keep this in our minds. Next. I think FEMAMA seeks innovation and stakeholder relationship. And what I'm going to present to you is a brief result of what I did in Brazil together with Argentina, Colombia, and Chile under the ICC-LA, Latin America, together with Harvard, UICC, and Novartis. And then we're going to talk a little bit about the document position paper that we just got from COVID lessons for the whole Brazil to work together. Next, I'm going to rush. How many minutes more I have? So the ICCI was an integrated cancer control initiative in Latin America. And this was very interesting because we managed to get a whole group of people working together, 27 stakeholders and 52 participants involved in a virtual roundtable discussion. And we managed to get recommendations for cancer control, and that was done during COVID. So we've been kind of smashed by COVID, and we kept doing this approach, and we're thinking how we're going to strengthen the healthcare system as a whole, organization and governance, financing, resource management, and service delivery. You see that this is what matters for any healthcare system. And we managed to get a report that is available. If you want to have this, I can provide you. Just get in touch with FEMAMA, and at the end, I'm going to put our contact. And we managed to get 3 highest priority, 3 high priority, and 3 medium priority. Next slide, please. So the study collaborates propose these 9 recommendations to consider in order to address the rising burden of cancer and the challenge that we are seeing in the field. Next. And I think we need to, as a highest priority, we need to improve coordination of cancer care and control to reduce fragmentation of the systems. We see delayed, as Cavaldo addressed before, delay in diagnosis and treatment, and we think that this is a lot to do with fragmentation of the service. So we need somehow to talk to our government, to talk to our partners, to see how we can deliver better service as in an integrated fashion. We need to improve the existing cancer registry. And we always, in this cancer registry, seeing 5 years before. It's like to see in the retro mirror, you know, like we never help the patients during their journey. We just come up with, sometimes even in Latin America, you don't have a country with a cancer registry yet. So we need to update and to value our cancer register, because this will make us to have more strategic plans for that, according to that. We need to conduct comprehensive analysis to identify priorities of cancer care and control to improve efficiency. Stephanie talked about efficiency. Here, efficiency and equity for resource allocation. COVID was a very impactful. It was very impactful in some areas because of this lack of equity. That we have capitals, cities with more than they need, and others with nothing to assist the patient. Next, as high priority, we will say that it would be very nice to have as an innovation hubs to design, develop, and implement innovations to improve cancer care. We need to have this small, not in size, but units that we need to start to, we need to invest and to see what is good for that area. And then perhaps replicate in other parts of the country. But we need these labs with real world data, real patients, at the real time, at real time. You see, real, because with all we're seeing is things that are coming later that we see when we see with very poor and data that we don't need. So sometimes we're collecting data that we don't need, and our government in Brazil has a lot of data, but based on how they are going to pay their services. And this is afterwards, it happened. So I think we need to restructure to deliver cancer service, to enable provision of consistent high quality. Nobody value the quality of what has been offered to the patient. We have like 15 chemotherapy this month, 17 surgery, blah, 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 numbers. But how good they were? What were the outcomes for that? This is, like nobody is interested in that. The patients are. So it's not quantity. We need to improve quality and effectiveness, efficiency, equity, how to respond to this cancer burden, because I think there is no other way away from implementing digital care pathways. We know that our countries are so big, so sometimes patients live so distantly, as Raquel mentioned. Digitally, we need to get into digital, and maybe this is not only healthcare people that has to think about that, but where are the other partners that could improve this? Next, and not less important, but this could be more long play, we need multi-sector actions to prioritize prevention, because we always talking about treatment, and we don't talk about prevention. We don't talk about controlling risk factors that are so important as obesity. That is not simple. The sweet, the sweet poison campaign that we have in Brazil now, that is doce veneno. This is like sugar. Nobody tells people that the sugar is poison for you, getting diabetes, getting blindness, and other things. So, sometimes we go to very hard tasks, and maybe if we start campaigning against the sugar intake, would be nice. Restructured payment model. Well, the payment for performance has to come in, and not payment for how many people, how many surgery, how many. No, it's performance. Next. Now that is something, next slide, please. I think before I finish, I have to, this is something that just being launched a week ago in Brazil that was the position paper from lessons of the pandemic. This is, I presented briefly at a side event at World Health Assembly almost a month ago, but now it's concise, now it's been launched, and we also have that in English, not Spanish yet, but perhaps we can deal with that. And what we're talking about here is coming from patients. Next, how the efforts to control the pandemic could be applied to oncology. Next, please. I'm rushing. FEMAMA proposed a national discussion among multi-stakeholder panel to point out recommendations for cancer control to government, private sector, and civil society entities to unite efforts to achieve the reduction of cancer morbidity and mortality more affected greatly by COVID. Okay, so next, you go understand. I can see that I have to show a graph here. Can you next slide, please? So we started to think about this last year, and we put together in March and April 2022. It's very, very fresh. 55 people involved in 3 virtual roundtable discussions. These people were like FEMAMA's network, patients, NGOs, not from patients, parliaments, institutions, pharma, and we talked about what were the lessons that these people, and this was more than 10 hours meetings, what were the lessons that we could apply to healthcare system and specifically oncology. Next, so we managed to get, look how interesting, this is Brazil's view, okay, but you are going to connect to this, I'm sure. So we saw during the pandemic that with joint efforts, it was possible to collect data to enable timely decision making. For example, there is this agency that was formed by media and communication industry that they put together the data every day on television saying, well, we are having more cancers, more COVID, we're having more cases, dying more, dying less, in this state, in that state. And this made the people, the community, to look at that and to react. Oh, we have to do something. We have to understand what's going on. So we managed to have timely decision making because the data was on real time. This was a very important strategy that was not government, was the private sector that came with this data. Integration of data information systems and levels of care. We knew we have an app in Brazil that we know where are the COVID patients. If they got into this, to the hospital, to not. So we could help the patient with COVID in real time. I'm talking there, I'm telling this insistently because this is what is lacking in most diseases, in diabetes, in acute diseases, but not necessarily infectious diseases, because Brazil has a very good track before vaccines and tracking infectious diseases, but doesn't apply to other non-communicable diseases. So we needed we saw appropriate financial resources and infrastructure allocation quickly to improve equity in patient care during COVID. Next slide, please. Also, we saw transparency on communication. Oh, now you have to wear masks. How you have to vaccinate. All these things that we don't talk about cancer or diabetes or cardiovascular disease. And the technology was a great enabler to health system with the telemedicine and consultations, and even what shall I do if I'm coughing? What shall I do if my sister is having this? So there was a mobilization because people were very afraid. They were so afraid of COVID, but they are not afraid of cancer. I don't understand that. You know, it's just like, doesn't get to me, this. So we need a multidisciplinary intersector. So let's go to the recommendations. I'll jump to the recommendations because this is the most important part. So next slide, please. We have, as I said, recommendations we're going under election time. Every 2 years we're having a kind of election here. So we are going to do a work with this policy, with this document, position paper, to give to our candidates, not only the presidents, to presidency, but also the members of parliament in state level and national level. And this is 75 NGOs in Brazil are going to do that as an advocacy, how can I say, as an advocacy approach with one paper, one document. So we need to improve cancer reporting and sharing information in a timely fashion to enable decision making. We have to promote the integration of information systems. We have to increase cancer's resource allocation and leverage the additional COVID-19 capacity for cancer. We have so many PCR labs in Brazil, all over the place, and you do too in England, you do too in Argentina. Why not to use this capacity, these labs, to work on cancer? We were talking just now about precision medicine. Precision medicine helped a lot COVID, and we need to have that extended to oncology. Next. Next slide, please. Expand and improve health communication to population. I think is a cancer you avoid. Media avoids only if they have a horrible case that was like, or a new drug that is not going to come to the patients in 10 years' time. Otherwise, it's not hot, the news. So we need to expand and improve health communication. Foster health technology broad discussion. I don't think that we have all these issues sorted out yet. The ethical issues, the protection of the data. We don't have that. So for COVID, nobody cared. But I'm sure that someone that is tested positive for mutations, maybe these people have to be protected some way from their employees. Otherwise, they're not going to give them a job. For example, we need to improve collaboration between different sectors and not keep talking among ourselves. The converted ones, I say. We all agree with all that. So we need to bring more people that are being left out of the discussion. Cancer is no doubt going to be the biggest cause of death in the next few years, if not already in some countries. So what we're waiting for. Next, I'm finishing, promise. So we need to humanize care. There is an R there that is a student bill. We need to bring the oncology. Please forgive me again. You can read any other diseases from the non-communicable disease world. We need to improve health financing because it's not cost, as Kovaldi said, is investment, and we need to put patient at the center to make sure that personalized care is going to come in. Next slide, please. Thank you very, very, very much. And I think, sorry if I got excited, but this subject is very, very close to my heart and to my mind too.
Okay, good. Okay. Thank you very much, Mara. I think you really spoke this through what is called feeling. And I was sitting listening to you. I was reflecting on the Motorcycle Diaries. This is about an Argentinian doctor who initially starts off a trip around America, being young, as fun-loving, easygoing, like everybody, and has a passion for mechanical motorbikes. And by the time he finishes his journey, Dr. Ernest Guerra becomes absolutely embittered by that the humanity and the soullessness of healthcare in Latin America. I think that's what was driving him. And he's misunderstood by many, but if you listen to his lecture to medical students in Havana, it's a very good online available resource, and he really pleads. And today I've been asked the same question, but in a different format, from Judith Rodriguez from Honduras. And she says, if you have lack of resources, then we get limited, it places limits on holistic patient care. But we do need that humanitarian education in healthcare. How do you propose that we can introduce this humanitarian education into our departments? I will first go to Raquel and then to Myra. Raquel?
Can you hear me okay?
Yes.
Okay, because my computer froze, but I'll trust you. And so I will continue. If I freeze as well, you let me know. But I think it's very relevant what has been asked. This is a huge, big call, long term, but I think that it's very obvious to us what we're going to get back by investing in this call. So I think what I would say is that when we're looking into, especially when you're talking about patient groups, disease specific, sometimes you're a small patient group, even if you're big, you're constantly firefighting. There's so much that you need to do. You're gonna go, oh my God, Raquel, don't give me another issue. Don't add to my cause. But I think that there is an opportunity to leverage, to take opportunity of these bigger agendas, such as sustainable development goals, such as, for some diseases, disabilities, human rights. And this is another one, humanizing healthcare and compassionate care. And I think that when you are making the cause for your own disease, that there is space to talk about good quality of care for people and how to do it. So I think that it goes together, and it's just by doing that, you're already part of the movement, you're already helping, and you're already helping generate results back. That would be my 2 cents.
Myra?
I think the education is, I think, in all senses, not only patients, but also health professional, healthcare people, is key for us to bring together the discussion, because I think that if you look at healthcare professionals, they were bombed, they were assaulted by all this pandemic, and they didn't know what to do. And I think in oncology, if we don't take the idea of oncology or even diabetes or other non-communicable diseases to primary care in a way that those professionals not only send people away to other places and then they will get rid of them because it's too complicated for me. And I think we should have to establish a coaching to these primary care health professionals. You see, like to have something that they could ask before sending people away. And when they send people to another service, to another place, they need to make sure that they are going to get there, because they don't. So I think what I'm bringing here the navigation motion of patients that will give them education on what they have to do. I think this notion about people lost during the pandemic, and if you didn't have a cough or a fever or something typical of COVID, you're not even seen. People don't even have a way where to go. But by then, let's take this opportunity. Let's take this idea of we need to coach patients, and sometimes this kind of meeting and our work in house in our own countries, we're doing that. But the health professionals from primary care, they are not having enough help. Raquel?
The next question is very important. I think, again, it's come from a young patient, and again, very good activist. Pilar has asked this, and I think if I frame it first, then you'll understand it. I was told long ago that if you're not registered, then you don't count, which means that your work doesn't count. She's asked the same question. Shouldn't there be registries in all diseases? And I think I know where she's coming from, because at the moment, many countries are pushing cancer registries as a high priority and forgetting other NCDs. So Pilar asked, should we have registries for other NCDs at an equal level as cancer registries? Raquel, I'm sure you said this because you've been asking for cancer registries on liver and hepatitis. You start, and then Mara will finish off. And we've just got 7 minutes to finish this, so please shut and shop. Thank you.
I'll be sharp. We need data. Without data, we don't go anywhere. Data moves mountains. If they say patients move mountains, we do, but we need a tool, and our tool is data. So, sharp. Was I sharp, Cavaldi?
Yes, that's it, to the point. Yeah, without data, we don't move, and what that movement matters to move. Myra, your 2 cents, as they say. How important is registries for others?
I'll change the name from the registry, because as I said, registry is something always in the past. It's very important to know, to look, but I like better the notion of notification.
Notification,
Okay.
Yes.
Because this is what happened during the pandemic. If you knew where the patients were, you could do something for that patient. So we've been defending in Brazil, and we managed to pass the law through Congress to sanction the law in 2019 about cancer notification. Never. So we were like hit by COVID, and that is still on paper. But if we knew where the patients were with cancer during COVID, we didn't have all these losses, because lots of people lost their life with lack of a tendency. So I think if we have, for example, for diabetes,
Thank you.
something that you could click and
Yes.
be notified.
That's it. Thank you. Thank you very much. I think it was a great session, and I think keep watching this. As I said to everybody, we are trying to plan something in Bhutan, where the health minister has invited us. So we may have a contingent of Latin American patients with us going to Bhutan. I think it will look like home to many of you. It's just as the Andes, a little bit higher, but that same culture thing. And we will address humanizing healthcare together. And please, let's plant those mangoes, I think, now for future. So thank you very much, everybody. And we will have, I'll hand over to Stephanie. Please, Stephanie.
Thank you all so much. It was a really amazing conversation. And now I'm thinking about the rights that we have to be educated as patients and what we need to do so that the health system works, so that we can be empowered, and that we can be those people fighting to have a voice, to have a seat on the table, to make the decisions about our lives, our health, our treatments, and to talk about how important the organizations as IEEPO and QUIDAR are, so that we can go ahead and that we can push these conversations and make the decisions about our health and our futures. So it was excellent. Thank you to the three of all. And now we are going to have a 5-minute break. We'll be back at 10:25 Mexico time to our third station, which is the regulation of medicine, and it's going to be awesome. It's going to be really incredible. And meanwhile, let me share with you that when you have the photo booth, you can take pictures, and remember to use the hashtag LAPC 2022 and Congreso Pacientes LATAM. All the posts are going to be in our social media booth that you can find on the lobby. So I don't know if you're waiting, go there and post your picture in Facebook, Instagram, Twitter. Remember that you can visit the exhibit hall where IEEPO and IEEPO members have set up virtual stalls with a variety of resources about their work. They are going to be open throughout the Congress and will be staffed with a live representative. So you can chat with them if you have any questions. You can also learn about the work of IEEPO members in Latin America through the videos that are going to be available in the auditorium through the breaks. And thank you all so much. You can go there, but come back because we will be here.